الرحيم. إني الدكتور ازهر عبد الحافظ جابر، تدريسي في كلية طب الأسنان جامعة بابل. سألقي على مسامعكم محاضرة بعنوان Treatment of Tuberculosis ضمن منهاج كلية طب الأسنان المرحلة الثالثة. Treatment of tuberculosis. The most widely encountered mycobacterial infections is tuberculosis. And tuberculosis is the leading cause worldwide of death from infection. Members of the genus Mycobacterium also cause leprosy, الجذام, as well as several tuberculosis-like human infections. Chemotherapy of tuberculosis. Mycobacterium tuberculosis can infect lungs, genitourinary tract, skeleton, and meninges. The organism grows slowly, thus the disease may have to be treated for 6 months to 2 years. It is a long period. Resistant organisms readily emerge, particularly in patients who have had prior therapy or who fail to adhere to the treatment protocol. Treatment of tuberculosis. There are 4 currently recommended first-line agents utilized for anti-tuberculosis therapy, while the second-line medications are either less effective or more toxic, and they are useful in patients who cannot tolerate the first-line drugs or who are infected with mycobacteria that are resistant to the first-line agents. First-line therapy include combination of isoniazid plus rifampin plus pyrazinamide plus ethambutol, while the second-line therapy or alternative agents include moxifloxacin, cycloserine, amikacin, ethionamide, aminosalicylic acid, and other agents. Strategies for addressing drug resistance. Although treatment regimens vary in duration and in the agents employed, they always include a minimum of 2 drugs, preferably with both being bactericidal. The multi-drug regimen is continued well beyond the disappearance of a clinical disease to eradicate any persistent organisms. Poor patient compliance is a problem. Initial course include combination of isoniazid plus rifampin plus ethambutol and pyrazinamide for 2 months, for the initial 2 months. Continuation phase, isoniazid plus rifampin for the next 4 months. Now we shall discuss each agent of those of the first-line therapy. First, isoniazid, or abbreviated as INH. It is a synthetic analog of pyridoxine, which is vitamin B6. It is the most potent of the anti-tubercular drugs, but is never given as a single agent in the treatment of active tuberculosis because resistant organisms rapidly emerge. Mechanism of action. Isoniazid, or INH, is a prodrug that is activated by mycobacterial catalase peroxidase enzyme, and the activated drug covalently binds to and inhibits some of type 2 fatty acid synthase enzymes which are involved in the production of mycolic acids, which are found in mycobacterial cell wall. Antibacterial spectrum of INH. INH is a bacteriostatic for bacilli in the stationary phase, but bactericidal for rapidly dividing organisms. INH is specific for treatment of Mycobacterium tuberculosis, although Mycobacterium kansasi, which is an organism that causes 3% of tuberculosis cases, may be susceptible at higher drug levels. Some pharmacokinetic properties of this drug: absorption of isoniazid is impaired if it is taken with food, particularly carbohydrates, or with aluminium-containing antacids. It diffuses into all body fluids, cells, and caseous material. CSF drug levels are about the same as those in the serum. This drug readily penetrates host cells and is effective against bacilli growing intracellularly. Adverse effects. Some of adverse effects of this drug include peripheral neuritis due to pyridoxine deficiency, which can be corrected by administered pyridoxine during therapy. Here a note to be mentioned: breast milk INH levels may be high enough to cause a pyridoxine deficiency in infants, in nursing mothers, and unless the mother is supplemented with vitamin B6. Second adverse effect, which is a common adverse effect, hepatitis and idiosyncratic hepatotoxicity. The second agent, rifampin, it is derived from the soil mold Streptomyces. It has broader antimicrobial activity than isoniazid and has found application in the treatment of a number of different bacterial infections. It is never given as a single agent in the treatment of active tuberculosis. Mechanism of action: rifampin blocks the transcription by interacting with bacterial but not human DNA-dependent RNA polymerase enzyme. Antimicrobial spectrum of rifampin: it is bactericidal for both intracellular and extracellular mycobacteria, including Mycobacterium tuberculosis and atypical mycobacteria such as Mycobacterium kansasi. It is effective against many gram-positive and gram-negative organisms and is frequently used prophylactically for individuals exposed to meningitis caused by meningococci or H. influenzae, that is Haemophilus influenzae. Rifampin is the most active anti-leprosy drug at present. So rifampin has a wide antimicrobial spectrum, not only on tuberculosis. Some pharmacokinetic properties: adequate levels are attained in the CSF even in the absence of inflammation. Rifampin itself can induce the hepatic mixed function oxidases, leading to a shortened half-life. Here a note to be mentioned: urine and feces as well as other secretions have an orange-red color, and patients should be forewarned. Tears may permanently stain soft contact lenses orange-red. Adverse effects: nausea, vomiting, and skin rash, hepatitis, and death due to liver failure, although it is rare. However, caution of this drug: the drug should be used wisely in patients who are alcoholic, elderly, or have chronic liver disease due to the increased incidence of severe hepatic dysfunction when rifampin is administered alone or concomitantly with isoniazid, the first drug. Drug interactions: because rifampin can induce a number of cytochrome P450 enzymes, it can decrease the half-lives of other drugs that are co-administered and metabolized by this system, and this may lead to a higher dose requirement for those agents. Examples of those agents which are affected by enzyme induction by rifampin: we have ketoconazole, clofibrate, digitoxin, prednisone, and other agents. The third agent, pyrazinamide. Pyrazinamide is orally effective bactericidal anti-tubercular agent used in combination with isoniazid, rifampin, and ethambutol. Mechanism of action of this drug is unknown, but theories are available. Pyrazinamide is active against tubercle bacilli in the acidic environment of lysosomes as well as in macrophages. Pyrazinamide distributes throughout the body, penetrating the CSF, and about 1% to 5% of patients taking isoniazid, rifampin, and pyrazinamide may experience liver dysfunction. Urate retention can also occur and may precipitate a gouty attack. Pyrazinamide, not only it, also ethambutol, the fourth drug, they inhibit the uric acid or excretion, and this will lead to urate retention. The fourth drug and the last one in the first line therapy, ethambutol, it is bacteriostatic and specific for most strains of Mycobacterium tuberculosis and Mycobacterium kansasi. Ethambutol inhibits the arabinosyl transferase, which is an enzyme that is important for the synthesis of Mycobacterium arabinogalactan cell wall. Penetration into the central nervous system is therapeutically adequate in tuberculous meningitis, so it is effective in the treatment of meningitis. Adverse effects of ethambutol include optic neuritis and also decreased urate excretion with gouty attack, similar to what is mentioned for pyrazinamide. This is the last topic to be discussed in this lecture. I hope it was comprehensive and informative for you. Thank you for your listening.